Let me just, I think most everyone here knows Dr. King. Dr. King is a part of the Advanced Lung Disease and Transplant group. He also directs inpatient respiratory services, oversees them, and he is here to talk about post-PTE management.
Okay, well, thanks, Oksana. Hi, everybody. So I just, wanted this to be memorable. So you'll always remember where you were when you heard my post-PTE talk, because it's the day that a bunch of dimwits stormed the Congress, and there was at the urging of our president. So that's a memorable event. So we've done about 5 PTE surgeries so far. And so, but we wanted to just sort of wing it those first 5, and then we'd give an official lecture about how to take care of them afterwards. Fortunately, they've all gone fine, and I think that's an important lesson is that depending on your patient selection and how good a job the surgeon does, it makes the care of these patients pretty easy. If you don't get a good hemodynamic response and they have RV failure, things can get complicated pretty quickly. So we're going to talk a little bit about some survival statistics on PTE, which is pulmonary thromboendarterectomy. That's basically the surgery that's done to remove blood clots and chronic thromboembolic pulmonary hypertension. We'll talk a little bit about how we select candidates, and then we'll go through some of the post-operative management. CTEPH can be a pretty bad disease. I actually saw a guy today that I had diagnosed with CTEPH when I was on active duty and referred him over here. And he's such a dummy that he can never get it together well enough that he completes all his testing and gets an evaluation done. And so hopefully this time we'll make it stick. But he's in this group where he's got mean PA pressures of about 40. So the higher your PA pressures and the longer the time out from that you are, your survival starts to go down. And so you can see if you have mean PA pressures greater than 50 and you don't do anything about it, by 6 years, you're almost certainly dead. And so it's a morbid disease. These patients have a lot of symptoms. And so it's certainly something that needs to be addressed and can progress over time as well. And so again, I mentioned if your mean PA pressure is greater than 50 and you don't do anything about it, there's an 80% mortality at 2 years. And so there's a number of different medical therapies and interventional therapies, but PTE, if you have disease that's amenable to surgery and you're an appropriate candidate for surgery, remains the gold standard and the best way to address this disease. And a lot of times when we're telling people about a diagnosis of pulmonary arterial hypertension, it's not a happy talk. Even there's a lot of things we can do for it, and therapies have advanced significantly, and these patients live longer and longer and feel better and live more normal lifestyles. And inevitably, it's a progressive disease, and patients, their lifestyle is your lifespan is limited, and they have limitations and have to take a lot of medications. But with CTEPH, and if you have surgical disease, you have the potential for a cure, and so that's an unusual form. I mean, I think the only other thing you could maybe say that for would be portopulmonary hypertension if the patient gets a liver transplant. But really, that's there's not many curable forms of pulmonary hypertension. And so when we're seeing these patients, we're trying to decide who's operable. And so, how do we do that? So things to consider, where's the clot? Is it accessible by surgery? Is the clot responsible for the hemodynamic impairment that you see? And also, can the patient tolerate the procedure? And so we weigh all those factors. And really, this isn't something that should be done just anywhere. It's a little nerve-wracking to start a program. I think Oksana could probably tell you that. And I'm sure Dan had some trepidation doing the first surgeries. You want to make sure you choose carefully and the patients do well. At places like UCSD, they're the most experienced center in the world and do the most, and they do about 200 a year. I think Temple does about 50 a year, although that might be falling off a little bit now that some other places are doing more. But this isn't something that you can just go to any hospital and have done, and it's something that really should only be done at centers of excellence. in terms of what's the hemodynamic significance of the clot, you want to make sure that if you're going to put somebody through open heart surgery, you're going to get enough clot out that it's going to reduce their PVR into a range that's sort of near normal-ish, and that they're going to get some benefit from it. You know, if you have a lot of really distal disease, you may not see that benefit. And sometimes patients, and I'd say it's not uncommon that patients have multiple issues. And so a lot of our patients aren't diagnosed with a pulmonary embolism and then followed up and found to have CTEPH, but we'll do imaging as part of the evaluation of a patient that's presenting with shortness of breath and pulmonary arterial hypertension. They're like, oh, they have a clot, and we work it up. And so some of these patients may have a clot that's small and insignificant, but they have, you know, say connective tissue disease associated pulmonary arterial hypertension. And a recipe for disaster for a CTEPH program is to operate on somebody with pulmonary arterial hypertension that has some sort of clot that's incidental, because those patients are not going to do well. So you want to choose carefully. I did want to mention here that sometimes we will do surgery for clot without pulmonary hypertension. And I know that seems like a crazy concept, like why put them through this big open heart surgery? Those patients don't have the same hemodynamic impairment, so the risk of the surgery is lower. But some of these patients can be quite symptomatic. I know Oksana had a patient that she sent out to UCSD that used to be an active duty Marine, and he was very symptomatic and went from running marathons to, you know, barely being able to, he looked like me when he was out there running. And so he, after surgery, he felt significantly better and was really glad that he went through it. And we've had a couple other cases that we turned down here recently and sent to UCSD. It may be something that we start dabbling in down the line, or if we had a patient that was really interested in surgery and just didn't have the means to get to San Diego, or a big center that does a lot of these, that might be something that you see here. So another thing to consider is the clot accessible by surgery. You know, traditionally, we only considered really proximal disease, but that's not really the case anymore. In this picture, you can see this person, it's right there in the right main stem pulmonary artery. And so this is kind of an easy decision that that's surgical disease. There's different types of disease. Type 1 is really in the major vessels. Type 2 is lobar and segmental vessels. Type 3 is confined to segmental and subsegmental. And type 4, this picture is a little bit deceiving because this is not the clot that you're seeing here. This is actually the intima. So they went into and did surgery, and they pulled the intima of the vessels out. So this white stuff here is actually, even though that the specimen they're showing there looks chunkier than the one in type 3, it's because it's the intima of the vessels. And so, which one of these are operable? So type 1, type 2. What do you guys think? Show of hands. Type 3? Yes, you're right. And then type 4, generally not. So, and type 3, I think you have to be, it has to be an experienced surgeon in a center that does a lot of this. So, if you just have, pretty, like subsegmental stuff, that would be a tough sell to do at a lot of programs. UCSD might, and some of the European centers might do that. I think segmental, sure, but type 3 is kind of on the fence. I think you have to use some clinical judgment. You also have to figure out who's operable. If somebody's, like our TAVR population, they're probably not the group that you're going to start looking for to do CTEPH surgery on. So really debilitated, really advanced age, significant underlying lung disease. Those are things that we would shy away from. Propensity to significant bleeding or bleeding diathesis, those are all things that you might steer clear. But if you choose wisely and it's an experienced center, it's a reasonably low risk procedure, 2.2% mortality at UCSD. The European centers quote about 4.7%. And you'll see this 2.2% can vary widely depending on how well the patient does with surgery. Some things that you might think would increase mortality, like really tall, prior sternotomy, obesity, don't really seem to increase mortality. Advanced age, so age greater than 70, increases your length of stay, but not necessarily your mortality. I would imagine they pretty carefully cherry pick which 70-plus-year-old patients they're operating on those. So I'd take that with a grain of salt. Some things that really do impact mortality: if they have coronary artery disease, it increases your in-hospital mortality by 5-fold and your 1-year mortality by 3 times. So coronary artery disease is something to pay attention to. But the big thing is really, what kind of hemodynamic response. So if you go in there and they leave the OR and they look like the same patient, they have this PVR that's greater than, 500. So what is that? Divide that by 80. What is that? 8 Wood units or so. It's like you didn't have surgery. Those patients have a 1 in 10 chance of dying in the hospital during that hospital stay. If you get their PVR less than 500, patients don't have right heart failure. They do quite well. I think my math stinks. What is 80 times 5 is 406. It's about 6 wood units is closer. Okay, sorry, I apologize for my poor math. I had a public education. It's not my fault. Other things I would say, if they have really poor rehab potential or significant lung disease, you might steer clear of those patients. These are some other risk factors. There's a fairly good review article about postoperative management of PTE patients. And so again, some of these preoperative things that we identified, getting it done at a podunk center, not a good thing. Really distal disease, their functional class, again, PVR that's super high. I think that's a double-edged sword. Like if your RV is really crappy, then maybe that increases your risk of undergoing surgery. They also stand to gain the most benefit from the procedure, particularly if you can get a lot of clot out and get their PVR down. If you have severe LV systolic dysfunction, you're older than 70, chronic pulmonary disease, and then post-operatively, the things we mentioned. All right, so of course, Dr. Schlobin picked an appropriate candidate, and Dr. Tang does a perfect surgery. So they get all this clot out. So now what? They drop him off, and they're like, "All right, Michael, here's your patient. Do the right thing. I'll see you tomorrow." And so, what is the right thing? Standard ventilator support is what we're doing here. And some of these things have been a little bit Inovatized, like we had Dan and Oksana and Mitch and all the CTEPH crew kind of talked about what to do. And some of these things are a little bit different than the way UCSD practices. They tend to use huge tidal volumes, 10 cc's per kilo of ideal body weight, and they think it has some sort of tamponading effect. I think that's kind of rubbish. And they actually did their own study thinking that maybe if you did more of a lung protective strategy, you'd cause less ventilator-induced lung injury. They did 6 cc's versus 10 cc's, and it looked at about 68 patients in each group. It really didn't make that much of a difference. My own personal bias is 10 cc's is kind of a crazy tidal volume for patients, particularly if they end up on the vent longer. And so we elected to go with 8 cc's per kilo. And there's data that supports 8 cc's being just as safe as 6 cc's in patients that don't have ARDS. It was a study called the PREVENT trial, and so I think there's some foundation for that. So that's what we roll with. And then, the complications to watch for in intubated patients, there's something called reperfusion injury. And so you take these vessels that have been sort of chronically occluded and you open them up and they get all this extra blood flow. And then in addition to that, they may have developed these bronchopulmonary collaterals because of that impaired flow. So you get sort of double blood flow. There can be venous lesions as well on the other side, and then once the vessels lose their autoregulation for a time, and they also get sort of leaky because their endothelium doesn't work, just because the surgeon's been messing around in there. And so when that all happens, you can get these areas of localized pulmonary edema, what they call reperfusion injury. It's more common in the lower lung fields, and it complicates like 30 to 40% of patients in the first 48 hours. And it's kind of like we see in our lung transplant patients, patients, right? You can have this primary graft dysfunction, and almost everybody's got some of it, right? And it's usually not a big deal, and you don't really have to do much with it. You just kind of diurese them. But some patients, it could be really, really severe. And in those patients, you might have to do more. And so this is a good example radiographically. You can see this person starts out on post-op day 1, and they've got, pretty clear chest x-ray, a little bit of stuff. And then by post-op day 2, they've got more areas of this kind of localized edema. And so what do we do for that? So PEEP can help. So using, positive pressure will help offset the effects. We tend to leave our patients on the vent for a day just to kind of hedge our bets. That's what UCSD does. Some other programs don't do that. And whether it's necessary is sort of debatable. I think it's not crazy to leave people on the ventilator, trying to hustle them off the vent and having to re-intubate them if they have bad reperfusion or they have significant bleeding, I think is probably a bigger deal as opposed to just letting them ride on the vent for one night. And it allows you some time for the PEEP to work, for you to diurese them and kind of assess where they're at. And so most patients you can leave on kind of moderate PEEP, 8 cc per kilo tidal volumes. If can tolerate it, at minimum a conservative fluid strategy, but a lot of times we'll gently diurese these patients. And then you also don't want to over support the RV with ionotropes. And so this is one big thing we preach. So when they come out, and I'll get into this a little more in the hemodynamics section, but if you have somebody that's got significant pulmonary hypertension and their PVR's up here for years and years and years, the right ventricle gets used to pumping against this high pressure and your left ventricle gets kind of lazy. And so all of a sudden you do surgery and you drop the PVR dramatically. Now your RV is pounding away already and it's not used to seeing that low a PVR. Then you throw on ionotropes and then you have this left ventricle that can't accommodate all that blood flow. So you can actually worsen that reperfusion injury. And so we will generally preach, support them to a lowish cardiac index, like 2 to 2.2, something along those lines. If you have severe cases of reperfusion injury, you can try adding inhaled nitric oxide if they're really hypoxic. They might require prolonged ventilator support. If they're really bad off, you can do VV ECMO. Steroids have been studied for prophylaxis and treatment. They don't help, so don't bother. And that's sort of reperfusion injury. Other things that can happen, they're basically slicing open the pulmonary vasculature, right? And so there's a predisposition to bleeding. And so patients can bleed. It's not uncommon, and how much bleeding they have kind of dictates what you have to do about it. So if you're suspicious that they're bleeding, because it may just look like pulmonary edema, like if you're looking at an X-ray, reperfusion injury and pulmonary hemorrhage would look very similar. And so you could do a bronchoscopy to confirm the presence and the location. If it's mild bleeding, you might just say, let's hold off a little longer on starting anticoagulation and just kind of monitor it. If it's more severe, you may need to sort of contain it because you don't want a ton of bleeding, soiling both lungs and making the person really difficult to oxygenate. And so bronchial blockers are reasonable in that setting. Look for other causes of coagulopathy. I mean, your guys are comfortable. A lot of these patients that we do pump runs on come out and they've got multiple derangements in their coag pathway and their platelets are low. And so you can correct those things. If they have severe cases, it could require IR embolization. And again, if they got very, very hypoxemic, you might need advanced ventilator support or even ECMO to sort of correct or kind of bridge them through while, from a hypoxemia standpoint until they recover. So you guys can see, this is what a bronchial blocker looks like. It's not like a super complicated procedure. It has a little loop here on the end of the bronchial blocker device that you loop around your bronchoscope, and you can guide your bronchoscope to the airway that you want, and then you unlasso it and blow up your balloon and then remove. And so, like, say the person's bleeding distal to this, at least this lung may be severely affected, but at least you've got one good lung to work with. So again, if you see somebody that's hypoxemic post-operatively, think of all the stuff that we normally think of. You know, do they have pulmonary edema because you unmasked their diastolic dysfunction when you did surgery? Do they have atelectasis? Do they have reperfusion edema or pulmonary hemorrhage? You know, and then normal stuff, pneumothorax, PE, infection, ET tubes malpositioned, et cetera, et cetera. And so it's all stuff that we're kind of used to dealing with. So what about the hemodynamics? You know, these patients have a number of factors that put them at risk for shock. And so far we've been very fortunate. Dr. Tang's brought everybody out looking pristine and dropped them off, and they've been very uncomplicated. You know, but the reason that I get paid the big money and drive a Hyundai is because you know, we can deal with this stuff if it happens. And so, you know, there's risk for tamponade. So that's something to think about. If they're in shock, you might just throw a probe on and see if there's evidence of an effusion. Postoperative, you know, vasoplegia, RV failure. They can have some degree of myocardial stunning. And so looking at their LV as well to see how that's faring. Vasodilation from sedation, rhythm issues, hypovolemia, bleeding, all the stuff we're used to seeing in sort of our general cardiac surgery crowd can happen to these patients. And the RV failure is a little bit unique because, you know, and so when the person comes out, it's nice to know what did they look like when they went in? And so Dr. Tang will know what their preoperative hemodynamics were, and it'll be in our notes. And then he'll also know what their post-op hemodynamics were, and they'll come to the unit with a Swan and an A-line. And so you'll be able to pretty quickly assess, like, okay, did we get a good response to surgery, or is this that patient with the PVR that's greater than 500 that I need to worry about and that's going to be really a problem child? And so again, you want to support their MAP, so MAP over 65. I think vasopressin is probably your best choice for initial pressor because it doesn't give you that propensity to arrhythmia, and it also won't increase your pulmonary pressure substantially, but it will increase your SVR more than your PVR, basically. Dr. Tang likes the dopamine, so do the guys at UCSD. I think it's probably fine. I think it's a little arrhythmogenic, but we don't use crazy high doses of it, something like 5. And a lot of times he'll tell you, like, let's wean that off gradually, and he'll have a plan in his brain in terms of how to do that, just to give a little bit of RV support. Again, you don't want to over support the person. And so if it depends again on the patient. So the patient that's doing well and had a great response, you know, you might not give them a ton of ionotropes, and you'll let their cardiac index ride a little bit low. You want to make sure they're still getting what they need though. So monitor urine output, creatinine, lactate, SVO2, you know, instituting that conservative fluid strategy and running them fairly dry is all reasonable. Arrhythmias are fairly common. You know, amiodarone is probably what I would reach for. I think these patients get loaded preoperatively with amio, just like all the other cardiac surgery patients. And, you know, again, if they get unstable, you would cardiovert. I would avoid calcium channel blockers. I probably should have written that in. If the patient has RV dysfunction, we generally frown upon aggressive use of, say, diltiazem because it impedes RV ionotropy. And so something to think about. You know, and again, other stuff that may help with PVR is, you know, correcting acidosis, correcting hypoxemia, et cetera. So let's say the patient does have postoperative RV failure, you know, that's what the PH service is around for. And so, you know, you probably get some help and get them involved. And we tend to think of the way that we approach RV failure. There's 3 big kind of categories of issue to address. You want to optimize their preload, you know, that big dilated RV. You want to diurese those patients down and try and get them back on the Starling, correct part of the Starling curve. So taking them out of arrhythmias, you know, with either a medication or electricity. Usually these patients need diuresis more so than further volume. You want to decrease their RV afterload. And so inhaled pulmonary vasodilators like nitric or Velitri are easy to add. Sildenafil is not totally crazy. if they were really, really bad off, we could consider IV prostanoids. That's something that, you'd want to weigh the risks and benefits of that carefully. They'd have to have a really horrible outcome post-operatively, but it is something that has been done in patients that had a poor outcome. You want to minimize the adverse effects of invasive mechanical ventilation by minimizing your pressures and, again, correct hypoxemia and acidosis, and then optimize their contractility. So again, dopamine is something you can use. You can also use milrinone or low-dose epi, sort of stuff that we do fairly regularly. Neurologic issues. There's a reasonably high incidence of these in patients that undergo CTEPH surgery, which is not a huge surprise for a couple reasons. Number one, these patients have some propensity to clotting, right? And so strokes are an issue. A lot of them may have a PFO. They have elevated pulmonary pressures. They're also at risk for bleeding, and so subdurals and intracranial hemorrhage are possible. And so they cite a rate of anywhere from 0.3 to 5.6% of cases, I think, depending on how you define a neurologic event. They do something called deep hypothermic circulatory arrest, which I think Dr. Tang mentioned in his lecture. And so because of that, you slow your metabolism. And so they're at risk for kind of slow emergence and delirium, depending on how their brain is, how well you're oxygenating them, and it might take time for them to wear off some of their sedation. When they come out, you want to warm them to normothermia, but avoid hyperthermia. I think standard sedation is overall okay. If they do have marked RV dysfunction and significant residual pH, I'd probably steer clear of propofol. It has a tendency to drop your systemic pressure more than your pulmonary pressures. But if they get a reasonably good response, a little bit of propofol is not totally crazy because it goes away quickly. Think about pain control. Precedex, I think, is reasonable. And you want to start weaning them when they arrive. And you can wake them up and usually get people comfortable. They can ride the vent overnight and extubate in the morning. What about anticoagulation? I think different programs have different philosophies. It's probably got to be somewhat tailored to the individual patient, and their risk of bleeding. And so it's something you should discuss with the surgeon, in terms of what they're comfortable with, because they probably have the best knowledge of their risk of bleeding post-operatively. But you don't want to, because these patients are so prone to forming clot, and that's kind of what got them into this mess in the first place, you don't want to withhold anticoagulation for like extended periods of time because we're worried about bleeding. And so we've been starting low-dose unfractionated heparin with no bolus on post-op day 1 pretty consistently. We haven't really run into any huge bleeding issues. We might have to reevaluate if we had a patient that was bleeding, and you might do something sort of middle of the road like DVT prophylaxis. In terms of long-term anticoagulation, it kind of depends on the patient characteristics. Most patients, Eliquis would be our DOAC of choice, and that's probably what they'll leave the hospital with. Although patients with a high BMI, I think Mary and I were talking about, we think 40 is probably that number. If your BMI is higher than 40, then you're at risk for failing DOACs. If you failed a DOAC in the past, or if you have antiphospholipid antibody syndrome, those would all be patients you would probably use warfarin selectively. Lovenox would also be a reasonable option. Other stuff, standard post-op care, PT/OT, feeds, nutrition, get their lines out and get them moving when appropriate. We'll typically do a TTE prior to discharge to rule out effusion. And then these patients need to be set up in the PH clinic for follow-up. And so we have this sort of regimented follow-up plan where we look for evidence of residual pH, and that helps us determine if they need further medications or if they will need BPA down the line. This is sort of a table that I threw in here because I thought you might want to review these slides later on. And it goes through basically what are some of the risk factors from a neuropulmonary perspective and how you would manage them. And then hemodynamics and hematologic, and it's pretty consistent with what we said. There's a couple little mild variations, but overall pretty much on point with what we're doing. And so I think if I had to summarize, I'd say it is a unique population that's at risk for complications. Although these patients, the postoperative care is quite similar to what we do with a lot of our cardiac surgery patients. And so it's not a totally mysterious new thing that we're doing. I think careful patient selection and good operative outcomes are really the key. That's what makes taking care of these patients really easy. Think about reperfusion injury and bleeding. Don't over support the RV. And if they do have RV failure, then, it requires some expert consultation. And Dr. Schlobin said she's available 24/7, 365 days a year. So I think that's going to do it.
So Dr. King, there was a question in the chat from Mahul.
Okay.
Asking, did they compare to high PEEP? I'm assuming regarding the study on the tidal volumes.
They only looked at tidal volumes, and they didn't really, the PEEP I think was standardized. They looked at 10 cc's versus 6 cc's. I think we've been doing 8 cc's of PEEP for kind of similar to what we do for the general cardiac surgery population. Honestly, Dan's made taking care of the 5, is it 5 that we've done? So easy. Every one of them's done really well. And so it's always this big buildup. And then I'm like, oh, I don't really have to do anything. We need to extubate tomorrow and we'll start some heparin. But we haven't dealt with a lot of post-operative issues because the PVRs have dropped dramatically, and they've all had essentially normal PA pressures and good-looking RVs, and it makes life easy. If we pick a loser for Dan, or if we have a bad just surgical result, it might make things more exciting. But knock on wood, we won't face that problem.
Cool. If anybody else has any questions, if you either want to put it in the chat or if you want to unmute and ask.
One thing I would say, almost everything that we're talking about with the hemodynamic stuff, it all applies to lung transplant in patients with pulmonary arterial hypertension. So it's a nice population to deal with, because it seems like we're going to have probably soon one of our sick PAH patients getting operated on, getting a lung transplant. And so a lot of these concepts of like dropping the PVR and don't over support the RV and things applies, almost exactly to what you would see with a pulmonary arterial hypertension patient that getting a lung transplant. Anybody else have any other comments, thoughts?
Yeah, I think, Chris, you made it crystal clear. Okay, so, well, great. It's another great talk. So if no one has